Hello. My name is Dr. Wei Chang Liu from the Department of Radiology at Cheongdam Wooridul Spine Hospital. Today's presentation focuses on MRI. This lecture was originally delivered during our Friday grand teleconference for clinicians. Based on feedback that portions of the material may also be helpful for patients, I am presenting it once again. Although I revised the content to make it easier for general viewers to understand, certain sections are inherently difficult to simplify. I appreciate your understanding. To begin, I personally have a strong interest in luxury goods. Over the past several years, we have worked to establish the MRI system at Wooridul Spine Hospital as a luxury MRI service. Our MRI has several features that distinguish it from systems used in other hospitals. The first is the scout image. In clinical practice, a vascular necrosis of the hip is sometimes misdiagnosed as lumbar disc herniation. This study examined the misdiagnosis rate of femoral head avascular necrosis. A review of 1471 patients diagnosed with hip AVN found that approximately 20% had been misdiagnosed at their initial visit, most commonly as lumbar intervertebral disc herniation. The scout image is a low-resolution sequence typically used for positioning during MRI acquisition. Most hospitals use the scout sequence solely for localization, but at Wooridul Spine Hospital, we include the hip joints so that AVN can be detected during a lumbar MRI study. A normal hip appears as an empty circle in the scout view. In this patient, however, a dark linear signal can be seen in both hips, indicating pathology. A dedicated hip MRI subsequently confirmed bilateral avascular necrosis. This next case involves a 74-year-old woman who underwent lumbar MRI for suspected disc herniation. The scout image showed a dark line in the left hip, and the dedicated hip MRI confirmed left-sided avascular necrosis. By including the hip joints in the scout sequence, we can significantly reduce the risk of misdiagnosing hip AVN. The second distinguishing feature is the T1 weighted sagittal sequence. Standard spine MRI generally includes T2 weighted images, which emphasize fluid, and T1 weighted images, which emphasize fat. Each sequence is obtained in both sagittal and axial planes. Because T1 weighted images have a relatively lower signal-to-noise ratio compared with T2 weighted images, they are sometimes undervalued. A 2012 AJR study reported that focal signal loss on T1 weighted imaging can be associated with critical conditions, including osteomyelitis, fractures, primary tumors, metastatic lesions, and hematologic malignancies. In this example, the lone lesion looks similar to a Schmorl's node on T2 weighted imaging, yet on T1 weighted imaging it shows features of metastatic disease. Likewise, the L2 lesion appears normal on T2, but clearly shows metastasis on T1. The L3 lesion resembles a benign hemangioma on T2, but again appears metastatic on T1 weighted imaging. Because important conditions such as fractures, malignancies, metastases, and hematologic cancers are best identified on T1 weighted imaging, we devote significant acquisition time to obtaining high-quality T1 sagittal sequences. Our T2 sagittal sequences also differ from those used in many hospitals. Wooridul Spine Hospital provides a larger number of sagittal slices compared with standard protocols. In the axial view, our sagittal plane covers a wider lateral range, allowing us to detect extraforaminal lesions that might otherwise be missed. Although many hospitals have now adopted broader coverage sagittal sequences, some still do not include the lateral extraforaminal regions. Our T2 axial sequences also differ. In endoscopic spine procedures, a shallow entry angle is necessary to reach posterior disc pathology. For this reason, our axial images are acquired with an extended field of view, which helps determine the optimal entry angle and trajectory, This also allows us to identify vessels and other critical structures along the approach path, ensuring safer procedures. Next is the CTL sequence. As we know, degenerative spinal disease often develops at multiple levels. When one region deteriorates, spinal balance becomes disrupted, and other levels can also become symptomatic. The CTL sequence can be considered a simplified full spine MRI. A study published in 2021 highlighted the importance of CTL imaging. Among 1,757 cervical spine patients and 2,266 lumbar spine patients who underwent MRI with an additional CTL sequence, 33.5% of cervical patients had concurrent lumbar pathology, and 14% of these required surgical or interventional treatment. Likewise, 28.5% of lumbar patients had concurrent cervical pathology, with approximately 10% requiring intervention. This patient has disc herniations in both the lumbar and thoracic spine. Another patient has neuroforaminal stenosis in the lumbar spine due to osteomalacia, along with cervical disc herniation. Since degenerative spinal disease often occurs simultaneously at multiple levels, CTL imaging is essential for accurate diagnosis and comprehensive treatment planning.